Hi everyone, my name is Sriteja, and today I have the pleasure of talking with Dr. Nadia Orosz,
Hi, everybody.
who is a doctor, and she'll be sharing with us her experiences and some advice on being a doctor and in the medical field. So, Dr. Nadia,
Yeah.
it's a pleasure to be with you
Oh,
today.
yeah. I'm happy to be here. Happy to answer questions.
Yeah, so first of all, do you want to tell the audience, what kind of doctor you are?
Yeah, so I practice internal medicine. I'm a hospitalist, and normally you do 4 years of medical school, and then you decide what kind of doctor you want to become. And then if you decide to go into internal medicine, you do another 3 years on top of that. Some people specialize even further and will go into specialty, cardiology, gastroenterology, things like this, and then that's an additional bit of schooling. But I stopped after 3 years and became a hospitalist, and I work mainly with patients who are admitted to the hospital for many different reasons. You have to know a little bit about everything, and you have to be a very good diagnostician. So I really like it.
So, Dr. Nadia, why did you choose medicine as your career
Oh.
choice? And is there any story behind it?
So that's a good question. It's kind of complicated. I come from a family of physicians, and I am the eldest of four. So I feel I was doomed maybe into becoming a doctor. Not really. But my father's a pathologist. My mom went to medical school in Mexico, and she didn't continue when she went to the US. She didn't do her residency, but they were both very strong in medicine. And I really enjoyed a lot of different things growing up: history, literature, especially poetry. And my parents' advice to me was always to pick something that I really enjoy that can support all the other things I really enjoy. So for me, I loved science, but I kind of like looking at things beyond a surface level. So I like the investigation. And I went into biochemistry for college. But in biochemistry, if you continue and pursue a PhD, you're working mostly like in a lab setting. And I really liked that, but I missed this kind of human element. And I think medicine is really beautiful because you have to know the science, but you also have to understand people to try to get their story out of them. And I could kind of incorporate all the other things I liked to do into medicine. So I would say, in a sense, my parents really gave me a strong influence, and I grew up around it. So I feel like I was kind of conditioned to think it's amazing, but at the same time, kind of organically, I fell into it, especially in college. So yeah, that's kind of the long story. But I told my parents for a long time I didn't want to go into medicine. I think just to kind of bother them.
Yeah.
But when you're when you're in college and you are on your own, you can kind of really dissect out what you want to do. And I really wanted to do it.
What inspired you to choose internal medicine as your specialty rather than going into all the different sorts of specialties that you mentioned before?
Yeah, so my dad is a pathologist, and I think if you are interested in medicine at all, you kind of, after a while, will realize that each specialty has a personality. And in part, it's a little bit of a joke, but part of it is actually true. The whole thing about surgeons being, very technical, not super emotional. Obviously, it's a stereotype, right? Neurology has its own stereotype. Psychiatry and internal medicine, we're kind of, I think, like the geeks of medicine, and we spend a long time thinking about things that they're consequential, but we spend a lot of time on electrolytes or kidney function. And I really liked kind of being able to mull over a problem. And also, I wasn't very good at anatomy, so I would never go into surgery. You would not want my hands performing surgery on your body. So I really did like kind of the more cerebral part of medicine. And then I grew up in a household, my grandmother lived with us until she passed away at 94. So I took care of her with my parents and would often feel very connected, I think, to elderly patients that I served in medical school, because I just felt very comfortable with these kind of elderly issues. And I didn't feel as comfortable with peds patients, so that eliminated pediatrics for me. And then in internal medicine, you have a lot of geriatric patients. You have a lot of conversations about goals of care. You deal a lot more with the aspect of life that is dealing, I think, more with deterioration, and you have to be approaching that with reverence. And I think I grew up with that aspect already kind of laid out. So that's my long answer on internal medicine. And why didn't I go into anything beyond that? I think you can. I think a lot of people in my group went on to do cardiology or hematology, gastroenterology, and that's great. I just needed to move on to the next part of life, I think, at that point. So for me, it was more personal reasons, but it is kind of what it is. Whatever you want to do is I think, is fine.
Yeah, like speaking about like parts of life, like take me through your like daily routine. So what do you do as like not as also like a person in the house, but also like as a hospitalist? Like what do you do? Like take me to your daily routine.
It really depends. So as a hospitalist, a lot of times you are doing what we call like shift work. So you have a set number of hours you're working per day. A lot of times it's like a 10-hour or 12-hour shift. And you are either admitting patients, so working very closely with the emergency room doctors, or your urgent care doctors, your primary care doctors for transfers, and kind of working up like an undifferentiated patient. So that's actually my favorite part, is admitting somebody and you're setting the tone for their whole hospitalization. So if you're not thinking of something, it might be missed completely, or it might delay a diagnosis by several days. So I like being able to look at a person and try to put the puzzle pieces together. And a lot of times, you're just waiting for a call from the emergency room telling you, hey, we have a patient. And a lot of admitting shifts tend to be kind of quiet in the morning. For some people, or for some reason, people come into the hospital in the later afternoon or at night. I don't know why exactly, but the nighttime will be pretty busy, and so will the evening. So you can get, between 5, maybe 10 patients in a shift, and you just basically, get a call from the emergency room doctor. You review the patient's chart. You kind of get a sense of what you think things are going to look like. Then you interview the patient. You do a physical exam. And sometimes the interview can really change what you were thinking, because on paper things can look very different, and history is very important. So that's something that I think you really have to take time doing as part of the process. And then you do a lot of documentation, you put in your orders, you communicate with your nursing staff, the hospital, and you get somebody admitted. And then the other part of being a hospitalist is rounding, we call it. So that's when you follow someone through their hospitalization and you make sure that everything is being done as it should be, and you're getting them to a point where they can be discharged from the hospital. So that's the other aspect of being a hospitalist. And then if you go into academic hospitalist medicine, you can work on different kinds of projects. And usually what we do as hospitalists is work on improving processes within the hospital and patient safety, utilization kind of issues. So, whatever you want to do, you have a lot of flexibility.
Wow, that's really interesting. I didn't know there were like so many steps. In like a doctor's daily routine.
Yeah.
So that's really interesting. So for you, like being a doctor, what is like the most inspiring thing that like every day you look forward to when you work, or something like that?
It depends. There's different things that can make you feel very good, like finding the right diagnosis and helping somebody quickly. So recently I had a patient come in who had altered mental status, we call it, person who was confused and had a fever. And sometimes you can wait a little bit of time to figure out what it is, and other times you don't have much opportunity. And this person ended up having meningitis, bacterial meningitis. And you can, if you don't catch that within 12 hours or so, especially the kind of meningitis they had, a person can die. So I really do enjoy that component of medicine where you're on a time crunch and you have to figure something out, and it greatly improves the morbidity or even the mortality that that person may experience. So I really enjoy that. But at the other end of the spectrum, I think a lot of times, especially in our culture and Western culture, we have a big problem talking about death and dying. So I will have a lot of people come in who are at that kind of transition point, but families, patients don't really know how to discuss a pivot or a bit of a philosophical change. So what I mean, instead of treating a disease, taking a chance to change the focus to, we don't have too much time. What do we want to do with that time? Do we want to invest in, diagnosis and therapies, or do we want to invest in quality? So on the one hand, I love finding and figuring out diagnoses and making people better. And on the other hand, I also really enjoy taking care of patients as they kind of go through that final process of life. And I really don't think that we should go through that in a hospital, in an ICU setting, hooked up to all these machines. I think that we should honor kind of a person as they're going through that process and try to focus a lot more on comfort. So it's kind of the two extremes, but I enjoy both.
Yeah, I mean, that's also one challenging aspects of your job. So are there any other challenging aspects that you would want to mention?
I mean, tons. The reality of a hospital, it's a political place, right? Doctors are people. You have to play well with your colleagues. You have to know how the system works internally. I think a big challenge for a lot of doctors nowadays is this thing called moral injury, especially with COVID. And just, I think the pandemic kind of accelerated this feeling amongst physicians, but within our culture, we're kind of limited in the way that we can practice medicine. So some of the challenges aren't based on what patients bring to the table, but more about what resources are allocated to people and what people have access to, I think, in our country. So, I mean, I won't get into the politics of it on here, but, things are going on in Texas right now that are quite frustrating to know about as a physician and a patient, just a person. So there's certain things I think about the profession that when you're in it, you realize that it's kind of an organic, breathing, living, imperfect thing, which is, it is what it is.
So Dr. Nadia, what exactly is moral injury? Because for me personally, I don't really know what that is. So if you want to explain that.
Yeah, so moral injury, it's a little bit hard to explain. But basically, it's kind of when you're in a system that isn't super set up or isn't set up to support you as well as it could. And within that system, you have a responsibility and a job to fulfill. And you have to do it, and you feel compelled to do it. And you want to do it. You want to do a good job with what you have. But let's say, for instance, and I'm not going to compare what I do to being at war. I think they're completely different. But a lot of people understand the whole war analogy, I think, a little bit better. But as a soldier in war, there are certain things that you have to do because you've been instructed to do it and you've been conditioned to do it. But these kinds of things sometimes have a negative impact on you at a moral level, For instance, in medicine, we will have a lot of times patients come in who are either unhomed or have social determinants of health, we call them, that don't really favor them to thrive, in the context of their medical diagnosis. So somebody who has diabetes, like type 2 diabetes, and they need insulin. Okay, what if you don't have access to a cell phone? What if you're homeless? What if you don't have a support system in place, like people that care about you, that can help you? So we see this, and as a physician, I will do my best that I can to help somebody, but I know that within the context of how we practice medicine in the US, there's a lot of things that they're not going to be able to have access to because they can't afford it, because they can't access primary care, and then we'll be taking care of them again in like a month. And then 2-3 months, they'll have an infection in their foot, and then they won't be able to salvage the foot, and then they'll have an amputation. And you see certain things happen, and it's not just, right? And I feel, in a sense, as a society, as a country, we're doing a little bit of harm. So we encounter these scenarios, throughout our daily practice. And also, there's moral injury that happens within the organization of just practicing medicine as well. You have to see so many patients at a time. And this is a little maybe controversial, but, you have administration, and you have the hospital as a business. And, patients, especially when it comes down to working with insurance companies, and maybe this shouldn't be in the video. I don't want to be preaching.
Yeah.
But, patients sometimes, they should be at the top of priority when we're making a decision. But a lot of times you will feel that they are not, and there's not that much that you can do about it outside from trying to do the best you can within your role. But you still don't feel like you're doing enough. So I think that kind of, for me, is what moral injury looks like. And it's different for everybody, but basically you're trying to do a good job, and you're doing the best you can, but it's not enough. And it can happen over and over. So, but that's one side of medicine. There's a lot more good too.
Yeah. I think that definitely brings in like the positives and negatives of medicine per se, like to light. So yeah, thank you so much for that insight. It's really gives me like a good understanding of like medicine and like the whole system in general, basically, of like a hospital and practicing medicine in like a practical real life sense. So yeah. And like to that point, is there any sort of advice or guidance that you would give people like me or people in high school who are like considering medicine or internal medicine? Is there any piece of advice that you would give?
Yeah, I mean, I think you have to be passionate about medicine, and I think you have to be passionate about taking good care of people. If you're in it to make money, if you're in it for the prestige, go into something else. You can make a lot more money doing other things. You can, you have to kind of have a very specific need to try to be a healer in whatever a healer means to you. But, it's a very difficult kind of career path to get into, but it's totally doable. And I don't think that you should be going into medicine for any other reason really than trying to be a healer and trying to really help people. It's cliche, but it's cliche because it's true. So for me, that's my advice. And if you really do feel passionate, medical school and all this stuff, it goes by very quickly too. And I think that the academics of it all are not as important as the passion that you feel internally. And you have to protect that as well as you go along, because there's plenty of times where you can get to a point where you feel burned out, but you have to protect that, and you have to, really kind of have a reverence for taking care of other people.
Yeah, I think passion is definitely like a really like important factor in becoming a doctor, because if you're not in it for like, if you're not passionate about doing your job, like what's really the point of like being at such an important part of a person's life? So yeah, definitely makes sense. So Dr. Nadia, what exactly is hospital medicine?
So hospital medicine is a specialty within internal medicine, and it basically is dealing with the hospitalized patient. So there's outpatient medicine. It's also known kind of as primary care if you don't specialize further within internal medicine, and you can also do primary care as a family medicine doctor as well. But hospitalist medicine really is about taking care of the hospitalized patient. So I talked a little bit about admitting and that process, but when you are rounding on patients, generally speaking, your shift is maybe 5 to 7 days. So you're with somebody for about a week of time, and you are coordinating all their hospital care. You are dictating kind of the treatment plan. If you need specialist input, somebody has had a stroke or somebody's had a heart attack, you are in charge of coordinating with the cardiology team or the neurology team, whatever specialist you're engaging with, carrying out that treatment plan, coordinating care with physical therapy, occupational therapy, speech therapy, lots of different moving parts. Mm-hmm. And I mentioned briefly before a little bit about social determinants of health. So is somebody homeless or unhoused? Is somebody visiting from another country? Is somebody dealing with a situation at home that isn't really tenable? So you also have a lot of meetings with case management, social work, who can kind of affect the discharge process and help set up resources in the outpatient world. And then you're working on discharging patients, at the end of the day, whether that is to a skilled nursing facility, to rehab, to home, to another facility. So there's a lot of kind of technical, non-medical stuff that you are in charge of. And, then obviously talking with the patient and explaining what's going on in a way they can kind of understand and take ownership of whatever their condition is, and talking with family members as well, trying to create a support system where people know what's going on and feel comfortable asking questions. So it can be a lot, and I think you have to be a very patient and articulate person. You have to be able to talk to people on all different levels. And with all different attitudes. So it's fun. It's challenging.
Mm-hmm. Yeah, definitely like a lot of moving parts, because on one hand you have to be like a doctor, a healer, but on the other hand you have to take care of all the administrative work as like an employee of the hospital, right?
Yeah, and just making sure medications are ordered as they should, where they should. It's a big picture, but also very granular. So we are very detail-oriented people, I think.
Yeah, and like moving on to like another like a fun question. Like this was all like super informative. Thank you so much for
I'm glad.
like all the detailed insights, and like now I have an idea of like who an internal medicine physician really is because of you. So
yes, we think a lot about sodium and your creatinines. So
a lot of specific stuff.
Yeah.
So like another fun question I wanted to ask is, if you hadn't pursued medicine, what other career field would you have gone into?
Oh, that's a good question. I really liked history, particularly like French Revolution history. Mm-hmm. They were the original disruptors, I feel. Mm-hmm. So I'm not sure what I would have done with it, but I enjoy hearing stories, and I also really liked writing, and I still write now as well, but I'm not a very good writer. But I think I probably would have pursued something in the liberal arts. But I think medicine was really, I can't think of like what else I would have gone into necessarily. So I never got that far, but I would take as many Western history courses as I could. And I think if you are thinking about medical school, you should try to also focus on having a well-rounded liberal arts education. So I don't know. That's a good question. I'll have to think about that a little bit more.
Yeah, that's super interesting. I didn't know that.
Yeah.
So Dr. Nadia, let's say like I'm a patient like walking in with some sort of pain. So take me through that process of like what actually happens and where do physicians like you come into the picture?
So yeah, that's a good question. Generally speaking, the emergency room doctors see patients with all different kinds of problems, and they kind of act as the initial screening. So sometimes you will be taking care of a patient and you have to have a very wide differential of what you're treating, otherwise you might miss something. So you can have people coming in with chest pain who have a pulmonary embolism, who have some kind of infection, maybe pericarditis, could have a pneumonia, could have some kind of cancer, could have a musculoskeletal issue. So there's a lot of different things that you have to keep an eye out for, and if you don't look for it, you can miss it. But if somebody's coming in with like classic chest pain, what I will do is I will review their chart, try to get as complete of a picture as I can about their past medical history, and then I'll go in and interview the patient. And a lot of times that interview, that history is kind of the most important. And as physicians, we tend to cut people off pretty early because we think we know, the whole story. But I try to give people as much time to talk through why they're in the hospital and, what brought them in. And sometimes you'll have somebody say, I was sick maybe a week ago and I was feeling really run down, and now I'm having chest pain and it only feels better if I sit forward. Okay, so that really kind of points to something like pericarditis. Or if somebody comes in and they say, well, I took a trip to Dubai and I just came back and my leg hurt like 4 days ago and it's a little bit swollen and now I'm having chest pain. That leads you much more down the road of this is a pulmonary embolism, and it dictates kind of how you order studies and what you do. And if you're dealing with somebody coming in with like classic chest pain who you think is having a cardiac episode, you would also, reach out to your cardiologist and have them, perform either like a stress test or a cath and kind of definitively diagnose the problem. And then, you would basically follow them through their hospital stay. So making sure that we're not really leaving any stones unturned. Once we found out the diagnosis, educating a patient on what that means and providing the right kind of treatment and medications. So that's kind of like a quick and dirty of, how I would manage somebody coming into the hospital with chest pain, typically.
Mm-hmm. Yeah, that makes a lot of sense now. Yeah,
it's a lot. I mean, I feel like I could talk for 10 hours about chest pain. So I don't know.
Yeah. Just another question that I had, like this is the last question. So like with the rise of AI, artificial intelligence, people are speculating that AI is going to take over a lot of jobs. And what do you think about the implications and impact about like AI in the medical field and maybe in internal medicine? Do you think it'll replace doctors, or do you think it'll help them with more technology and tools? Or what do you think about this whole AI scenario in the medical field?
That's a good question. Maybe this is kind of cavalier, but I really like AI. I love disruption. I think medicine, it's about time we get rid of pagers. And I think, AI will obviously replace certain kinds of jobs. That's just the way it is. But I think it's going to act more as a tool for physicians. I think it's going to allow us to be a bit more efficient. I use it actually in my daily practice. I use an AI scribe, and it allows me to actually focus in on the patient. And I have my digital scribe, transcribe, come up with a note for me, and then I edit that. And that would eliminate, typically like 30 minutes of work per patient.
Wow.
Having something, recording the conversation, having it go to kind of like a HIPAA compliant cloud, and then spit out an actual note. It's not just transcribing the note for me, it's synthesizing the data. So I think that AI is just like any kind of tool. It can be used for good, it can be used for bad. It's kind of like, in a sense, money. It just depends, I think, on what the person who is holding it wants to do with it. And the more opportunities we have to become efficient in processes that don't really require a lot of mental capacity, I think it's great. So it will probably get rid of certain kinds of jobs, like, basic transcribers who are relied on in the outpatient office setting, and, ED doctors tend to use transcribers. So I think that at some point that will probably be a job of the past. But, as far as getting rid of radiologists and pathologists and internists and things like this, I just don't see it making that jump yet. We'll see. Maybe I'll be eating my words in 10, 15 years, but I'm a big fan.
Yeah, that's super interesting. So like in the future, you won't see like, instead of you walk into the hospital, instead of like you coming in, you won't see like a robot coming in.
Well, I mean, so that kind of enters into the territory of telemedicine a little bit. I do telemedicine as well. I think that it's going to be very hard to replace the human connection, because you can see somebody, let's say, over a monitor, and we do have radiologists, okay, who interpret imaging from a remote location. We have teleneurologists. You can make anything kind of remote. I don't think that's the biggest issue, but I do think that there's something that gets taken away, maybe about 20% or so, at least for me when I'm doing a televisit versus an in-person visit. You need your five senses kind of to process information, and we take it for granted because we think that it's all cerebral, but it's actually, information is all around you, and you're synthesizing it a little bit subconsciously. So I feel in those situations, you get a little bit of dulled capacity, I think. So number one, doing something kind of tele or remote has a good, it serves a good purpose in a lot, but maybe 20% of cases you're not going to get as good of a result as if you were in person. The other thing is, when you're working with AI a little bit is, it's built off the back of the real interaction, how to kind of like how reCAPTCHA works, and you need kind of people to test that out. And I don't know if AI is going to necessarily have the capacity, maybe it will, to replace a physician when you're coming down to that clinical decision making. It's probably really good at exams. I mean, it's beat out physicians on the USMLE and, board exams. But is it going to understand like the nuances of working with different cultures, or different sexes, or patients who are communicating something that needs to be interpreted with a little bit of a human touch? I don't know. Maybe it will, but I'm not really threatened by AI in that capacity. What I want AI to do is eliminate all the boring and tedious and documentation kind of things that I have to do to let me actually focus like 100% on the person in front of me.
Yeah, that's like really amazing insight. Yeah, super interesting. I have like a little bit of experience like in AI, and I also am considering like a medical route. So I just wanted to see like what it will look like in the future, especially like the opinion of a person who's like in the medical field already. So, yeah.
I mean, look at medicine 100 years ago and look at medicine today. The way we're treating patients now, in 100 years, people are going to look back at us and be like, can you imagine that's what they used to do? Just as we look back. So I think that technology had a huge role in the changes that have occurred over the last 100 years. And I'm really excited to see what things are going to look like. I mean, I won't be around, but next 50 years, let's say, I'm really excited to see how we're going to be treating patients with certain cancers that we couldn't cure today. And I think that we're not going to be able to have that big leap without the changes we're seeing in AI and machine learning and all this now.
Yeah, super interesting. So yeah,
no, thank you.
Those are all the questions I had for today. Thank you so much for watching, everyone. Comment down below the biggest thing that you've learned, because for me, I've learned a lot about medicine and internal medicine. So feel free to like, comment, and subscribe, and we'll see you in the next interview. Bye.
Thanks.